So now you are the senior most in America. That's how you no one is there.
Of the chronic things, yes. For the chronic therapies, I'm using it most.
The fitness all over. And
Uh, what do there is and one is doesn't actually location connected online. And it is just really any different relatively seems to be a object to the day-to-day, but then there is something extra, but in the day, which we do not know and don't know. So they are two always there. I pleasure of welcoming the entire audience in a conversation at Mumbai, Hyderabad, Chennai, Kolkata, and Delhi. And also welcome our audience to my president on the YouTube channel. Technology and part of the marketing and Procare-CV and what taking care of different brands and it's my pleasure to be here. Can that that all the CME why all the hard to take care of despite all the you taken of the time to present here and to confidence with your presence and be a part of this educational piece out here. So introduce you was for something about the second license join the spread video what we expect for you. You present my team video and then we would like to take this way forward.
Macleods Pharmaceuticals Limited, a global pharmaceutical company based in India, engaged in developing, manufacturing and marketing a wide range of formulations across major therapy areas, including manufacturing of APIs. The seventh largest pharma company in India and the second largest in the domestic covered market in fiscal 2021. Having a presence across India and globally, a footprint that extends to more than 170 countries. A global highest in the number of WHO pre-qualified products, as well as the global highest in the number of WHO pre-qualified anti-TB registrations. Macleods, successful approvals for product registrations, filing of drug master files for APIs, 9 manufacturing facilities located across India, with one upcoming unit at Jammu. Macleods, committed to providing accessible and affordable therapeutics, with an aim to improve the quality of life for patients. Macleods Pharmaceuticals Limited, challenging frontiers in healthcare.
You have to. I inform you about that. I'm really glad to know that you're looking forward to 50 delegates across all locations. And we will be expecting almost more than 1,000 students coming in this event. Request your full participation in this event. And to take this event further, I would request so something on it. See revisions between the 16 methods. So take it forward, reduce our students. Thank you so much.
thank you so much, Mr. Robin. So very good evening, one and all, and uh, we all have gathered here for an academic feast that is to follow, as you all know. We often discuss lifestyle disorders, non-communicable diseases, especially with a focus on diabetes. As you all know, you might be probably getting an invite for diabetes every other day. But are we ignoring a greater pandemic out there, which probably has an incidence of more than 3 times diabetes in India? So, are we discussing hypertension in Indian settings? Well, hypertension accounting for India having 315 million hypertension patients. Thank you. And not just to us, but even further unique. As you all know, our patient does not only have hypertension, he also has a clustering of multiple other cardiovascular factors. So, what are your takeaways? How should you be managing these patients? What should be your targets? What else should you take care of in 2024?
ये ब्लूटूथ
Discuss that on the same we have in the stage.
भी माइक का आवाज
Maybe the stage is involved. So, right, CME, we have considered micro whose professor of medicine and understand knowledge of medicine with the hypertension, the expressed of the ASH and the ASH represented status of health, as well as the general of the ASH ISH. We facilitate Dr. Kumar online since 2003 in New York, and we welcome her. Welcome. Right here from Mumbai, we have the honor of introducing our chief moderator, Professor Dr. Sunny Shetty, who is not introduced in the field of medicine and cardiology, as you all rightfully know, but nevertheless, the honors. So, sir, as the emeritus professor at University of Mumbai, is the director of the department of the domain at the hospital, the chief managing director and founder of the Living Center, and has multiple accolades to attend. He is also served as the president of the History of India in Mumbai 2020 and 2022. And is currently invited to the chair of the
आप बोल रहे थे सुन ही नहीं सकते तो पहले
Sultan Chetty and Australian was the head of hospitals. There's a felicitate on the head. Is there this is our next moderator joining us from Delhi. We have Dr. Ajit Kumar, who's expert director of Therapeutic New Delhi. I call upon Mr. Sanjeev to felicitate Dr. Edward Delhi. Coming into Kolkata, we have Dr. Ariham Kar, who's the chief of the cancer lab in Consultant Analysis. Kolkata. And looking at Chennai, Kolkata, felicitate. Coming from Bengaluru, we have who's the Department of Cardiology, ASI Hospital, Bengaluru. They call upon Mr. Neha Shade locally. From Hyderabad, we have Dr. Joel Christopher, who's the Associate Director of we call upon Mr. Steve Vindeshwar, Vice President of Marketing, Defense State. From the list, from Chennai, we have Dr. Kari, who's the Senior Consultant in International Cardiologist. They call upon Mr. from the Veterans State, Defense State. This is customary in the Indian tradition, which you all know. We call upon all the coordinators, including our own chief coordinator, to light the knowledge so that we take blessing and open our minds together anymore.
yeah.
So, taking proceedings ahead, I now invite our chief moderator, beautiful speaker, Mr. Siddharth Shetty. Take you guys. Sir, over to you.
I think because of the audio transmission problem, we missed the other presentation.
Yeah.
So, it's a pleasure to have you here.
Hello.
So nice. Wow. So, from my
Thank you. Welcome all. I hope we will be able to hear better from New York. Yes. On it?
Michael Weber and all my colleague moderators at the different part of our country and my friends. At the outset, let me thank Team Macleod for organizing this very important webinar and hybrid program plus physical meet. What I'm going to do for the next 15-20 minutes is to speak to you about hypertension management. What are the challenges and Indian perspective? Basically, what we need to see the enhanced hypertension diagnosis with precise BP identification and monitoring. As you see in this slide, and that is very, very important. Next is optimizing the medication regimen to improve the hypertension control, and then selecting and titrating the antihypertensive for consistent 24-hour BP control. And this will promote active involvement of patient and physicians in the management. These are the common challenges what we are facing. As Dr. Partha mentioned in his introduction, if you see the awareness, treatment, and the control status as shown here, when you see 100 patients with hypertension, 28% aware of it, on treatment about 14.5%, and 12.6% are under control. So you can see the magnitude of the problem, that though it is common illness, but the awareness, treatment, and the under control is much desirable. So now, what are the barriers to this effective hypertension management? These are the three key issues. One is the low adherence as far as the patient is concerned to the therapy. And then the therapeutic inertia both by the physicians and the doctors and the patients and the health system issues. Now, when you look at the non-adherence, the common thing as mentioned here is the patient-related, like the health literacy, actual and perceived side effects, forgetfulness, condition-related like lack of symptoms. You know that hypertension is a silent disease till you get into the symptoms. Then the therapy-related, many times we give medication, side effects of the medicine can again make patient to discontinue the therapy. And therefore, when we select therapy, it has to be almost like a placebo, like side effects. And then the socio-economic system, like cost of the medication, some difference in the ethnicity groups, etc. And finally, healthcare related. That means the lack of team-based care, clinician burnout, almost a careless attitude, even among us, physician to the patient care. So all these amounts to non-adherence to the therapy. So when you look at the medication adherence, which is an important sign for measuring and managing the hypertension. So key is initiation and persistence of the therapy and the precise implementation of the dosage regimen. That is very, very important in the sense, if you give a single dose, that is better than two doses. And if you give two or three in a fixed dose combination, it is still better. If you see this particular slide, you see treatment initiated in a newly diagnosed hypertension. It can be well controlled or you can have a resistant hypertension. Then you have got a suboptimal BP control, all are interrelated. So we need to see when we are treating a patient with a hypertensive patient. Therapeutic inertia is basically depends, one, because of the, as even we as physicians see difference in the guideline regularly like European, whereas ACC a little different. And then the patient perspectives and the demands, attitude of the patient. So here, most important is the patient-doctor relations, how we put across the patient why medication is required. And that is very important. Also, we must have shared decision making. Both we physicians and the patient should have a shared decision before, the clinical uncertainty, accuracy of measurement versus waste of time, and the competing demands like patient, centeredness versus the clinical myopia. So basically, what I'm trying to say that we have to have a appropriate, action with the care, between the inappropriate inertia versus appropriate inaction. We have to have a balance for a better adherence to the therapy. When you look at the therapeutic inertia and a long-term blood pressure control, as shown here, one of the study, Monte Carlo simulation study, that when systolic blood pressure less than 120, and if there is you see here when there is no inertia, see the control of the patient as shown here in BP almost like less than 120 and 120 to 130. As you can see, the inertia is there, BP almost more than 140, suggesting that removal of therapeutic inertia is important when we initiate the medication and when patient has to take this medicine long term, irrespective of the BP measurement technique. Now, these are the few things, clinical inertia, like physician factors, almost about 50%, 30% patient factors, and about 20% office system factors. As shown, all these different factors, like in the goal setting pathology, failed to initiate treatment, like physicians also are very important, have an important role to play when you're treating an hypertensive patient. Of course, patients are, important role because unfortunately, because hypertension is asymptomatic like diabetes and dyslipidemia, many times they deny the disease. And we all physicians, when we see in our offices BP, quite high level we measure and we see, but patients do not believe that they've got this problem. Essentially because of the no symptoms, silent disease, and the low health literacy and medication side effect, cost of medication. These are also reality between our country because the poverty line in our country is quite huge in magnitude. So cost of medication. So we must give some cheaper medication at the same time, minimum medication, not too many medication. Of course, the office system factor, like all those, we don't plan properly. like no clinical guideline properly, no disease registry, all this, the inertia, office system inertia factors. So patient barriers, as I mentioned, healthcare barriers, system barriers, as I mentioned previously, these are the three major issues when you are talking about non-health. Now let us look at the hypertension mediated organ dysfunction called HMO. And that basically means that when we see a patient with hypertension, particularly our Indian patient, we have a multiple cluster of the severe spectrum. Dr. Partha in introduction did mention hypertension is one of the problems. These all are basically due to metabolic syndrome and many diseases like diabetes, pre-diabetes, dyslipidemia will component of metabolic disease. So if you see in this slide, almost about 101.3 million diabetes, pre-diabetic or 136 million. You see dyslipidemia, the number of people see the hypertension about this, see the generalized obesity. So we have this particular something like a genetic predisposition due to metabolic syndrome. And on the top of that, our management, that is epigenetics, environmental factor, our habits like, smoking and all, these environmental factors on the base genetics, epigenetics is the cause of main issue, and they all related to the adiposopathy. Basically, we have adiposopathy and adiposity, which is essentially apple shape obesity or abdominal obesity. So that is why currently, this particular entire risk factor is called a CKM, that is cardio-kidney metabolic syndrome. And to that extent of late, even the liver is added because even the liver, the NASH, etc., are part of the same component. So cardio, kidney, metabolic, liver syndrome, like, and they're basically starting from genetic predisposition. On the top of that, environmental factors. Now, when you look at the asymptomatic patient versus asymptomatic, and then the symptomatic hypertensive patient, we know that the hypertensive patient basically, these are the three main things: kidney, heart, and the brain. And if you see the oligosymptomatic, they are mild, like a proteinuria or an atherosclerosis, LVH, retinopathy, and this Bill-Swing lesion. And when it becomes symptomatic, by the time you are symptomatic, you already got an established renal disease, established cardiac disease, and then of course, TIA, dementia, etc. And we have to pick up patient at this stage asymptomatic or the pre-oligosymptomatic. Mind you, all these three diseases, hypertension, diabetes, dyslipidemia, have a common soil hypothesis, and we have an opportunity to treat at this stage. Most of the cardiac disease like CAD, coronary artery disease, heart failure, stroke, etc., atherosclerotic cardiovascular disease can be easily prevented. Of course, by the time symptomatic, you have got this, and when patient comes in the end stage, and many times we see patient stages, for end stage renal disease, myocardial infarction, heart failure, arrhythmia, stroke, etc. And then of course this. So this is the stage what we must aim for, and that is where we have to create an awareness. Remember why we treat hypertension for these three main reasons. Heart failure, 50% reduction with blood pressure control. So they reduce the cardiovascular risk by 50%. Myocardial infarction for 20 to 25, and the stroke. One of the important, in patient education, we must mention a patient who is hypertensive and has no symptoms. We must impress upon them that stroke is easily prevented if we control that. And this is a dreaded, highly morbid illness. And if you tell that point many times in my experience over almost 4 decades, this helps very much for our patient because stroke is one thing which a common man understands in simple language. And remember, every 20/10 rise in blood pressure, starting from 115/75, and if you see this, CV mortality risk doubles. And therefore, I'm more favoring of ACC guideline, 2017 JNC 8, whereas the ESC guidelines are a little bit, not that aggressive, though current ESC 24 guideline have come to hear about ACC guideline. We'll talk about it later. So this is what we get if you control the blood pressure and see the CKD. Every 10 millimeter increase in systolic blood pressure is going to increase developing CKD by 6% and also decline in GGFR. Additional 0.2 ml per minute per per year, one first plant at 1.73. So this is the decline in GFR. If the increase of systolic blood pressure by 10, and this is increasing developing CKD. Now let us look at the drug therapy in hypertension, particularly for our setting. Important, whenever we are looking at the blood pressure, is the BP control all throughout the day, 24 hours. 24 BP control, controlling the variability, circadian variation like early morning surge. These are the three most important factors to prevent any organ damage, whether it's the heart, brain, eyes, kidney, etc. If you see here, this is what strict control is required, particularly for us, like most of the now current guidelines to mention, if it is tolerable and the patient can take, and if patient is young particularly, this is the level of blood pressure we must achieve. BP variability, particularly morning surge of blood pressure, is a cause of stroke and many vascular events. So we must give a long-acting. All these things problem will be clear if you give a long-acting drug beyond 24 hours, and that is what is our current principle. Now, nocturnal BP fall is common, about 10 to 20%. In some patients with CKD, this doesn't happen. In fact, night the BP can go up, so we have to select out medication accordingly. So 24-hour management of BP control, is important, both quality, quantity, and the quality. Because quantity means we have to measure in the office, and you know that many times automated BP reading in the office is done. Manual we don't take nowadays to prevent all those white coat effect. Or we can take the BP monitoring, which is again very important. Ambulatories can be done occasionally, but it's very cumbersome. Home BP monitoring and automated office BP monitoring are two important, method to see that the control is strict. And of course, the quality of BP control, as I mentioned, reduce the BP variability and reduce the nocturnal BP. Few drugs, particularly the nocturnal BP, is a diuretic, SGLT2 inhibitor, DARD, and whereas they reduce the BP variability, long-acting like angiotensin receptor blocker, long-acting calcium channel blocker, any drug which works beyond 24 hours will be better. This is one slide. If you understand, I think I've done my job because this is the latest ESH 2024 called Master Plan. Master means M stands for measuring the BP. Remember, in hypertension, everything revolves around measuring the BP. You make a diagnosis on basis of the measuring. So we have to give importance to white code, automated office BP, taking BP at home, and occasionally ambulatory BP. And that's very important. That's M stands for master or rather measure. A stands for assessing the patient. You have to look at multiple, like particularly hypertension, mediated target organ damage. So look at the retina for any changes, cardiogram for any electrical hypertrophy, urine examination, any albuminuria, etc. And then comes the, select therapy, ST for selecting the therapy. And that, again, depending on the individual, we have to individualize the medication, one which works beyond 24 hours. And the reason what I mentioned earlier stands to here. And then, of course, evaluate the response. Importantly, we must see whatever therapy you have selected, do the BPS come to the target. As I showed in the beginning, the early part of my presentation, how only hardly 12.5% are optimum control. So this is a master plan. Measure, assess, select therapy, and then evaluate the response. The simple, mnemonic master. So evidence-based combos are important. Monotherapy often falls short in normalizing BP. Many times we give dual two drugs in a low dose to normalize the BP. And that step care approach, what used to do earlier is no more. Different and complementary mechanism actions are used, like effective combination of ARBs, angiotensin receptor blocker with calcium channel blocker and diuretic. We know that angiotensin receptor blocker with the diuretic or with CCB or three together are the drug of choice. ACE inhibitor we hardly use in hypertension because of its side effects, etc. And today, angiotensin receptor blockers have moved beyond point that probably ACE inhibitor hypertension alone may not need. While BP reduction is important, and certain drug class and combination are better for cardiovascular risk reduction. So selection of the hypertension drug dependent on this is little sort of too busy slide, but this is another slide which again gives you everything about what is the latest like last month we had a hypertension or rather ESH conference in UK, and this is the guideline, the latest one. As I mentioned, step one is adding low dose of two drugs like half or each with CCB or diuretic. Then the next step is to add diuretic, thiazide or thiazide like diuretic. We more of chlorthalidone or even the hydrochlorothiazide also is coming back. Occasionally, indapamide also can be used. And then when the drug is not this is not effective, then you have to add other drugs as shown here, additional therapy area. Here like resistant hypertension as shown here. Like spironolactone is one drug. Beta blocker, alpha blocker, the centrally acting drug like the clonidine, moxidine, and then renal denervation therapy. If you got heart failure, then RNA, HGL2 other drugs. And in case of CKD, necessarily SGLT2. And recently we have a non-steroidal selective MRAs like finerenone. And these are the use of diuretics. Whenever our GFR is less than 30, then there is a place to use loop diuretics, or we can use the combined the thiazide diuretic plus loop diuretics. And the use of beta blocker we can add at the fourth step here. Resistant hypertension, we have to give all the drugs in the maximum dose, including the diuretic. And then, generally the target, what I mentioned, office target, the what I mentioned earlier, and that is what we have to follow. This is what the assessment of patient should be adapted according to the severity of hypertension. Standard history taking is very important, and this gives us all the like what we take history, like other cardiovascular risk factors, comorbidities, symptoms of an hypertension mediated organ dysfunction. Second possibility and etc. We have to take a history and examine the patient to look for all these things. And common blood tests, what we do, like blood count, creatinine, eGFR, potassium, electrolytes, blood sugar, A1C, lipid, etc. And then examination for microalbuminuria or albuminuria, albumin creatinine ratio, and some valid ECG, and sometimes echocardiography. When you're suspecting mediate hypertension mediated organ damage, echo, MRI, coronary calcium score, kidney point ultrasonography, Doppler ultrasound to rule out renovascular disease, maybe the carotid ultrasound as a marker of atherosclerosis. Important ankle brachial index, very very important and simple to do. Pulse velocity also can be done. With the brain point of view, whenever you have a suspicion of target organ damage, we can do CT, MRI, and cognitive function test, and of course fundoscopy, retinal microvasculature. And whenever BP is not under control, we refer to the specialist, where therapy is, more, more drugs are added. Like there is a term called resistant and the refractory hypertension. Maybe in the panel discussion we can discuss on that. And whenever there is an hypertension emergency or urgencies, acute heart failure, acute stroke, etc., and this particularly the pheochromocytoma, etc., we can admit this patient. Importantly, ARB is one of the important drugs today in our armamentarium of hypertension management, right from the beginning of the entire cardiovascular continuum. We know today we talk about the pathophysiology on the basis of cardiovascular continuum. That means the risk factor as shown here. Hypertension gives rise to atherosclerotic hypertrophy, gives rise to myocardial infarction, stroke. We did mention why hypertension should be treated, remodeling, and ventricular dilatation, cognitive dysfunction, congestive heart failure, secondary stroke, etc. So these all can be easily prevented if you start right at this stage, because this drug has got the every steps it works. And this is what the final slide telling you that how the comprehensive hypertension treatment protocol. Most important, the accurate blood pressure measurement. Don't be in a hurry to diagnose hypertension for the first reading. Importantly, you must take office automated or ambulatory. Ambulatory is difficult, at least the home BP monitoring, which is now easy to do. check properly blood pressure, and make a correct diagnosis. Optimal blood pressure target we must set in at the beginning only. Young patient, even 120/80 should be good. CKD and all, again, we have to be more aggressive. Patient with multiple comorbidities, we have to be very aggressive. Particularly patient with diabetes, dyslipidemia, etc. Atherosclerotic cardiovascular risk calculation should be done because this patient also may have a dyslipidemia, he may have a diabetes, so you must rule out atherosclerotic cardiovascular disease developing. Team-based approach is important, like a dietitian, nutritionist, physician, etc. Many times in the office we don't have time, but we must press upon this team-based approach, lifestyle modification, medication initiation, intensification. Consider medication cost, very important formulation. So here very, very important single pill, like a fixed dose combination of two in one tablet or three in one tablet are the preferred, and that's the way forward in most of the guidelines today. Supportive strategy for medication adherence is very important. We must impress the patient why they require hypertension control, though they have no symptom. One of the important thing is a stroke. Tell them stroke. You are going to get stroke, the adherence is good. And that's my personal opinion. Of course, follow-up is important. Just one time checking is not enough. Thank you very much.
Hand over the session to Spike on his session on hypertension. Over to you.
Are we ready to start?
Yes, doctor.
Well, good evening, everybody. And it's a real pleasure to be talking to you from the other side of the world and to be sharing with you some thoughts about hypertension, although you have already just heard a very excellent summary of contemporary approaches to treating high blood pressure. And I think it's fascinating that no matter where we are on the face of this planet, we are really working to deal with the same kinds of problems. And they are problems. Hypertension seems so simple, and yet it has proved to be very difficult for us to deal with. Let's go to the next slide. Focus for the moment on what hypertension guidelines tell us about when to start the therapy for hypertension and what kind of blood pressure target should we choose. That, to my mind, is what most doctors want to hear from guidelines, Most doctors know a lot about hypertension, but what are the instructions, or what is the information that guides us in doing the best possible job? So let's go to the next slide. And this is a strange way to start in a sense, but I'm showing you a single clinical trial called SPRINT that was published about 8 or 9 years ago and changed everything in hypertension. And the whole point of the SPRINT trial was to compare an aggressive approach to treating hypertension, getting the systolic down to less than 120, as compared with what was then the usual target of less than 140. And this study has now been repeated in different ways by different people, but the story remains the same. And as we go to the next slide, what we see is that standard therapy, in other words, shooting for 140 systolic, as compared with intensive therapy, shooting for 120, there was a very significant difference. People whose blood pressure was reduced to less than 120 had a 25% reduction in mortality, in all sorts of major cardiovascular outcomes. It was really a remarkable step forward, and based on this study, guidelines throughout the world changed quite quickly. And now finally, as I'll show you in a moment, even the European guidelines are now asking for an aggressive approach to treating hypertension. Yes, I know, when you have to get down to somewhere in the 120s, it's more work than just getting down to somewhere around 140. But the benefit to patients is really quite remarkable when we make that extra effort. Let's go to the next slide. These are data in the patients in SPRINT who are aged more than 75. Why am I talking about people aged more than 75? In fact, the average for this group of people was age was about 81. And the point I'm making is that compared with standard treatment, intensive treatment was associated with exactly the same benefits as in younger people. Just because you are 70 or 75 or 80 or more than 80 doesn't mean that we have to compromise on treatment. Yes, we might be more careful in older people. We mightn't be as aggressive in getting to blood pressure targets so quickly as perhaps in younger people, but the benefits are just as powerful. And in fact, if you look at the very bottom of the slide, a 33% reduction in all-cause mortality when blood pressure was treated as close as possible to 120. I think in the people aged more than 75, they got it down to about 122. Really a dramatic change in how we think about treating older people as well as people at all ages. Let's go to the next slide. This was a very interesting, meta-analysis done at the time when the American guideline in 2017, put out by the American College of Cardiology and the American Heart Association, was making its recommendation, and they believed that based on SPRINT, at the very least, we should say it's important to get a systolic pressure less than 130. This was a meta-analysis that we're now looking at that was sponsored by the Guidelines Committee, Professor Paul Welton and the experts at the American College of Cardiology and the American Heart Association. They actually had this meta-analysis done in 19 studies, large numbers of patients, to confirm that independent of SPRINT, blood pressures less than 130 were associated with significant reductions in heart attacks, strokes, and heart failure. So we were all now very confident at the recommendation to get to less than 130. Let's go to the next slide. Next slide, please. And so this is the way that the American experts categorized hypertension or blood pressure back in 2017. By the way, there has not been a new version of these guidelines. Here we are in 2024. Maybe in the next year or two, we will see, I'm not sure, but I suspect we will see a new guideline coming out in America, which shows how satisfied we have been with what was published in 2017. And you can see here, normal blood pressure, less than 120, elevated blood pressure into the 120s, and stage 1, where hypertension begins, is at 130 systolic, and stage 2, which is where we say this is really something that must be treated promptly, begins at 140. So blood pressures that a few years ago were considered acceptable are now an indication to start treatment. Very interesting. Let's go to the next slide, which shows the Indian blood pressure guideline recommendation in 2020. So this came after the American recommendation. And they say if you've got normal blood pressure, no indication for pharmacologic therapy. Maybe if the pressure's a bit on the high side, you might think about lifestyle changes, and we'll come back to that in a minute. But if you look in the middle of the slide, they say that the treatment target should be less than 130 over 80, exactly the same as in the United States, if the age is less than 60, but it can be a little higher in the 130s for people aged over 60. Well, I will slightly disagree with this guideline and say if you can get your older patients' blood pressures down into the 120s, all the better. Now, sometimes they won't tolerate it. And of course, then you have to back off. You can't be too aggressive in older people. But if you can comfortably get the pressure down to less than 130, do it, because the benefits are very high. And the Indian guideline also says focus on non-pharmacologic therapy. We'll get there in a second. Next slide, please. So the 2024 European Society of Cardiology guideline for the management of hypertension was just presented in London at the meetings of the European Society of Cardiology. And let's look at the highlights of this brand new guideline, just a few weeks old. Let's go to the next slide. And they now proudly announce the new target in Europe. And guess what it is? It's between 120 and 129. In other words, once again, less than 130. And I think it's wonderful now that the American guideline, the European guideline, and the Indian guideline all recognize that if possible, patients should have systolic pressures less than 130. Now, they do say, well, be careful. Some people who have orthostatic hypotension, you may have to back off, maybe not be so aggressive. They say people aged 85 or more, you may want to be a little less aggressive. Now in India, they said less than people over 60, you should be careful. In Europe, they say you only need to be careful after the age of 85. And you know something? My experience is that older people, yes, they may be a little frail at times, not doing as well as they did when they were a lot younger. But so many of the patients I see in their 60s, 70s, and 80s are still living active lives and so much in need of good hypertension control. Because when you get to that age, strokes, heart attacks, heart failure are all waiting for you. And anything you can do to delay those outcomes or prevent them, obviously, that's what we want to do. Let's go to the next slide. Although treatment with medications is the usual approach for blood pressure control. And yes, we're going to have to use medications in probably 95% of our patients. We must remember, and all the guidelines say this, we must remember that lifestyle changes can be very valuable in preventing and treating hypertension. Let's take a quick look. I'm not going to spend a lot of time on this. Let's go to the next slide. And this makes the obvious point that losing weight is very beneficial. And it's interesting to me in the United States, because in America, we've known for years that obesity is a serious problem. And we've put it down to the fact that in America, Western Europe, which are reasonably affluent countries, people tend to overeat. They can afford food, they eat too much of it. And that's why we have so much obesity. It fascinates me now to learn that in India, obesity is also a major issue and a big part of the problem of cardiovascular disease and hypertension. Very simply, this is a meta-analysis, and it makes the point that for every kilogram of weight that a patient loses, there's a reduction of about 1.5 millimeters of mercury in systolic blood pressure. So if you can just get someone to lose 3 or 4 kilograms, or 5 or 6 pounds, as we would say in the States, that's going to give you a reduction in blood pressure of 6 or 7 millimeters of mercury. That's almost as good as taking a drug. And it's not only good for reducing blood pressure, but it's also good for lipids, it's good for diabetes, it's good for overall health. So this is an obvious thing to do. Next slide. The other big subject in lifestyle changes is salt. We all eat far too much salt. And I'm sorry to say, in India, the problem is just as bad as it is anywhere else. Now, I happen to love Indian food, and we have some very good Indian restaurants, both in New York and where I'm currently, we have a home as well in California. We have some excellent Indian food here. One thing I know, I go out, we have a wonderful dinner, and I come home and I'm feeling so thirsty because I've just eaten so much salt. And that's something we have to work on. How can we reduce salt in the foods we eat on a regular basis? This was a study showing a reduction in salt intake from the usual 10 or 11 grams a day that most people eat. If you reduce it just to 6 grams a day, there are reductions of 6 or 7 millimeters of mercury in blood pressure. And that's something we all have to work on all around the world. And the biggest way of doing this is to talk to the manufacturers of processed foods and to the chains of restaurants that put out high salt food. It's not just things in our own home. It has to be public policy that gets salt reduction accomplished. So important. The next slide, please, looks at the use of potassium chloride rather than sodium chloride as a way of reducing the problem of too much sodium. And we know now that dietary potassium lowers blood pressure. It's a very useful strategy. So if we could replace some of the common salt we use, sodium chloride, with dietary potassium chloride, we would see very beneficial effects on blood pressure. In China, this has now become a major issue, and it's easily available. I would suspect it's also available in India, as it is here in the States, though not as available as it should be. But this is somewhere that we're heading towards. If we can make our food with potassium rather than sodium chloride, that would be very beneficial. Let's go to the next slide. I think this is the last of the non-pharmacologic treatments, exercise. And we all know that if you can exercise on a regular basis, and it doesn't have to be strenuous exercise. I'm not talking about running marathons or doing crazy things like that. I'm just talking about going for a brisk walk, 30, 40 minutes, 5 days of the week. It's pleasant to get out and walk and enjoy the fresh air. And if you can walk at a good steady pace for 30, 40 minutes a few times a week, that is going to help reduce blood pressure. And we can sometimes see very nice reductions in blood pressure along, by the way, with reductions in body weight. So that's what I wanted to say about lifestyle changes, but let's keep moving. Next slide, please. There are several reasons, and you already heard earlier this evening, for poor responses to medication therapy, including the fact that some people are taking blood pressure raising drugs, for instance, pain medications like the non-steroidal anti-inflammatory drugs. Too much salt in the diets, obviously that interferes with medications. Cost to the patients, some people can't afford all the drugs we would like to prescribe. Secondary hypertension, and I don't have time to talk about it today, but aldosterone excess is far more common than we used to think. Sleep apnea, another common thing to think about if blood pressure is not being well controlled. But the main reason, as you already heard a little earlier today, very nicely presented, by the way, I really enjoyed the earlier presentation. The main reason for poor therapy results is that patients do not take their medications reliably. Let's go to the next slide. This is, in my opinion, a terrible slide because it shows control rates in the United States over time, going back a few decades, and then somewhere it was getting better and better. More and more people being treated were getting their blood pressure under control. And then in about 2012, it started to get worse. Now, this was before COVID, so we can't blame COVID for our poor performance in treating hypertension. In fact, it began before COVID. Why? Well, again, you heard a lot of excellent suggestions made in the earlier presentation. But one of the big problems here in the States, I suspect it may be the same in India, is that most hypertension is taken care of by primary care physicians, general practitioners, general internists, very often gynecologists for middle-aged women patients. These doctors are too busy. They've only got 6, 7, 8, maybe 10 minutes for each patient. They don't have time to sit down and discuss details with patients, particularly when they're seeing a patient and they have to remind the patient, have you had your flu shots? Have you had your vaccinations? Are you getting a breast exam if you're a woman? Asking men about their prostate, asking people how well they're sleeping, all the things that GPs are expected to do. There's not enough time left for dealing with hypertension. And this is a problem we're going to have to figure out because hypertension deserves to be treated far better than we're doing it right now. Let's go to the next slide. India, the story is a little different. And because the population is so large and there are so many people who still have inadequate access to healthcare, though that is improving quite dramatically, and I'm delighted to hear about that. But of people with hypertension in India, only about a third of them actually know that they have high blood pressure. So they're in blissful ignorance of the fact that they have something going on that's making them at high risk for strokes, heart attacks, and heart failure, and kidney disease if it comes to that. Not everybody who knows they've got hypertension is getting treatment, and we're now down to really a relatively small percentage. The best thing I can say, though, is that most of the people who are on treatment are getting their blood pressure treated pretty well. So if we can only increase access to care for people with hypertension, get them to see doctors, it turns out that Indian doctors do a pretty good job of treating hypertension once they have the patient in their office or in their clinic. And that's a big public health issue that has to be addressed in India, as in every country, including the United States, by the way. We have tens of millions of people here who have hypertension and are not getting treated at all. It's a real shame and in some ways a disgrace. Let's go to the next slide. This is just a comment that I always enjoyed from Dr. Akhala, going back now about 10 years, making the point that perhaps the people in India who have the poorest outcomes are those who live in rural areas. That's not to say that people who live in urban areas, the big cities, do that much better. They do better in the big cities, but people out in the countryside, away from big cities, really get very little good management for hypertension. Again, a public health issue, and it's no good us talking about what's the best way to treat hypertension. The first job for much of our population is to let them know that they have hypertension and to figure out ways of getting at least some kind of treatment put into place. Let's go on to the next slide, please. Non-adherence, and you already heard an excellent discussion of this. This is a study based on, what is it, 1, 2, 3, 4, 5, 6, 7, 8, 9 different studies, which showed that in patients whose blood pressure is not well controlled, the proportion of patients actually taking the medications is only about half. Why is it that people will get a prescription, they'll fill the prescription, they've got all these pills in a bottle, they know these pills will reduce their blood pressure, and they do not take the pills reliably? And it's not always a matter of cost. It's not a matter of some of the usual explanations we give. And we still have to learn why it is that people do not take their hypertension as seriously as they should. Let's go to the next slide. Getting patients to be responsible for their own hypertension treatment by measuring blood pressures at home can be very helpful. And I know now more and more people in India have access to home blood pressure devices. Not everybody by any means, but a lot of people have these devices. And telling patients to measure their blood pressure every day and write it down on a sheet of paper forces them, and it's just a good behavior modification, forces them to think about the importance of treating their blood pressure, and we get nice improvement. So if we go to the next slide, this is actually a study from Korea, South Korea, showing in blue, let's look at the extreme left side there, people experience when they started measuring their blood pressure at home, we saw a reduction of about 13 millimeters of mercury in systolic pressure and about 8 millimeters of mercury in diastolic pressure. So just making patients aware of their blood pressure makes them much better at taking their medication. So it's a big improvement in taking meds and a big improvement in blood pressure. Simple story, but it works very well. Let's go to our next slide. All the guidelines say that the key to improving blood pressure control is recognizing that when we are adjusting medicines, increasing the dose of a medication is far less effective for reducing blood pressure than adding an additional drug. Most drugs that we use for treating hypertension are reasonably effective even in low doses. Going to a higher dose, yes, improves the reduction in blood pressure to some extent, but it's far better to add a second drug. And let's look at this on the next slide. This is a look at different classes of drugs, and it's a little hard to read, but we're looking at thiazides, beta blockers, angiotensin receptor blockers, calcium blockers, and so forth. And what we see, if we just look at the one on the extreme left, the blue column shows the benefit of adding a second drug. The red column shows the benefit of doubling the dose. Well, doubling the dose helps a bit, but adding a second drug adds so much more. And given that we don't have too many visits before we are expected to get blood pressure under control, bearing in mind we really have to be aggressive about people getting under control, this is a strong piece of information that's quoted by all the guidelines for advocating the use of combination treatment. One drug is good sometimes, but we should normally be thinking of two drugs and starting that right from the beginning and getting the maximum effect as quickly as possible. Let's go on to the next slide. Another method recommended by all the guidelines is to use single pill drug combinations. In other words, if you're going to give 2 medicines or 3 medicines, it's much better to give them in a single pill. It is so nice to say to a patient, I am going to control your blood pressure with just 1 pill a day. You can take it in the morning, you can take it in the evening, it doesn't matter very much. Just 1 pill a day, and you are going to have excellent blood pressure control, at least in 80% of cases. Let's go to the next slide. This is the finding, first of all, that if you are going to be taking multiple drugs and with multiple tablets as compared with getting a single pill combination, we find that the single pill combination is associated with somewhere between a 20 and 30% improvement in patients actually getting blood pressure under control and in them adhering to their treatment. There's no question, one pill a day is the solution to a lot of poorly controlled hypertension. Let's not waste time on this anymore. Let's go to the next slide. These are the guidelines from the European authorities saying what you all already know and you already heard earlier today. Treatment should start in general with a 2-drug combination because that is the best way to get to control quickly. Patients love it. They think this doctor knows what he or she is doing. They've made a smart move here. I'm just taking this 1 pill, and guess what? My pressure is so good now. And the drugs we would normally choose would be an ARB or an ACE inhibitor, combined either with a calcium channel blocker. Amlodipine is commonly used, but it can be other calcium channel blockers too. I know in India you have a good selection of CCBs, or it can be combined, the ARB, with the diuretic. And if that doesn't work, you now go to 3 drugs in 1 tablet, which would be the ARB plus the calcium blocker plus the diuretic. And we'll look at that in a moment, how effective that can be. Let's go to the next slide, because the next slide is the brand new slide from just a couple of weeks ago in London when the European Society of Cardiology, which is different from the European Society of Hypertension, though a fair number of the same people are involved, again emphasizing, first of all, get the blood pressure down into the 120, 129 range, and start with ARBs combined with either a calcium blocker or a diuretic, exactly what we've already been talking about. I'm only showing this slide to say that everybody now agrees. The Americans, the Europeans, both of their guidelines, and by the way, Canadians, Australians, and I very strongly suspect the authorities in India as well. So let's move on to the next slide and ask the question, why have the angiotensin blockers become the foundation of hypertension therapy? We like them because they reduce blood pressure regardless of whether people are young or old. They provide such strong cardiovascular protection. They provide kidney protection. And they don't have side effects. In fact, they're the only class of hypertension drugs which, when they were compared with placebo, were actually better tolerated than placebo. They really are probably the best tolerated hypertension drug ever developed. And that's true of all of the drugs in this class. But let's move on from this slide to the next slide. This is experience with olmesartan, which is extremely popular in the United States because it's probably the most powerful of our angiotensin receptor blockers. But this is an Indian study showing over time how on the left systolic pressure and on the right diastolic pressure were reduced by using olmesartan. It's very well tolerated, very effective. In fact, let's go to the next slide. Just to make the point that from the doctor's point of view on the right and the patient's point of view on the left, these drugs are extraordinarily well tolerated. We see that very, very few people complained about side effects or difficulty taking these drugs. Way over 95% of patients really liked taking the angiotensin receptor blockers. Okay, let's go to the next slide. That point is well made. This is a comparison done by Suzanne Operel, who was the president of the American Heart Association, a very distinguished hypertension scholar in the United States, together with a bunch of other leading people in the United States. This was a comparison of olmesartan with other angiotensin receptor blockers. And let's take a look at those data in the next slide, please. It's a little hard to read, but on the left is olmesartan, very nice fall in blood pressure. And then we're looking at losartan. It has a decent fall, but not as much as olmesartan. Next to it is valsartan. And then finally, in the dark blue color, is irbesartan. They all work well, but olmesartan in its base dose, its first starting dose, is the most effective. Let's go to the next slide. And this is, again, a comparison, now optimizing doses. And we see that olmesartan does very well, does somewhat better than telmisartan, in fact, significantly better than telmisartan. Now, telmisartan is a good drug, but olmesartan is significantly stronger by about 4 or 5 millimeters of mercury. And that makes a big difference. We already talked about how a few millimeters of mercury do have a big effect on ultimate outcomes. And then finally, we see on the right side of the slide, losartan. Again, I like it. It's a very good drug, but not quite as good as telmisartan, and neither of them as good as olmesartan in terms of reducing blood pressure. Let's go to the next slide. Since we were talking about combination therapy, what we're looking at, the 4 sets of data on the left, the most one on the left, that is looking at the effect of a low dose of olmesartan. It gets the pressure down very well. The next is a higher dose of olmesartan. It does a bit better. But then if we just add a low dose of hydrochlorothiazide, we get a very nice additional effect. And if we increase the dose of hydrochlorothiazide, which is the final set of columns, we get even more of a reduction in blood pressure. So this emphasizes the importance of, yes, by all means, if you want to start with one drug, start with olmesartan, and that'll, in a number of patients, be all you ever need to do. But rather than playing with doses, add hydrochlorothiazide will give you a very good result, an outstanding result. Let's go to the next slide, which is the same story, but now instead of using hydrochlorothiazide to add to the olmesartan, what about a calcium channel blocker, in this case amlodipine? And we see in yellow olmesartan in 3 doses, pretty good. Then we see all by itself amlodipine in 2 doses, pretty good. But best of all, with either 5 or 10 of amlodipine, we see Very nice combination with olmesartan. So this is the other approach. I personally like to use an ARB plus a calcium channel blocker as my starting treatment. It's very well tolerated, excellent results, and you can see really big falls in blood pressure. But let's go to the next slide, which is the Trinity pivotal trial for the 3-drug combination. And just look on the right side at the systolic blood pressure. And what we're looking at is the 2-drug. This is fascinating how this study was done. We're looking in that very pale color, we're looking at the combination of amlodipine and hydrochlorothiazide, pretty good. Then we're looking at the combination of olmesartan and hydrochlorothiazide, very good. Then we're looking at the combination of olmesartan plus amlodipine, very good. But then finally, in that purple color, best of all, the 3-drug combination. And the 3-drug combination is about 8 or 9 millimeters of mercury more powerful than the 2-drug combination. And basically, just about everybody responds well to this approach. And in the end, if this is all we ever did, we would have a fabulous effect on treating hypertension throughout our communities. Let's go to the next slide, which is just to show that when you start this sort of treatment, it works very quickly. By 2 weeks, using the 3-drug combination, there is this dramatic, better than 30 millimeters of mercury, in fact, better than 35 millimeters of mercury reduction in blood pressure. You don't have to wait forever. It happens, actually, this shows 2 weeks. My experience is you see it within a couple of days. Let's go to the next slide, which is a study from Austria, from Europe. And this was not done in your usual hypertensive patients. This was done in patients who were very hard to treat and could be randomized either to those blue columns, which was telling doctors to do the best you can with standard approaches to treating hypertension, as compared with using olmesartan combinations. And what we see is just using what I've been talking about, olmesartan plus hydrochlorothiazide and amlodipine, whatever you want to use, that the olmesartan combination is significantly better than what other approaches to treatment could give us. About 80% of patients were controlled, and this is in patients who were known to be hard to control. If we had done this study in all comers and all people with hypertension, we'd be looking at control rates probably of better than 90%. So let's go to the very last slide, my end slide, just to summarize. All the international hypertension guidelines are in agreement. First of all, aim for blood pressures of less than 130/80, if tolerated, but even in older people, for the most part, this is tolerated. And all the guidelines agree, use single pill, 2 or 3 drug combinations for efficacy and adherence. As we've discussed, the core drug, the basic drug in these combinations, is usually an angiotensin receptor blocker, mainly used with either amlodipine or diuretic or both of those, whatever is necessary to get the blood pressure under control. And finally, as I think many of you already know, olmesartan has emerged as the most effective of the angiotensin receptor blockers, and as part of single pill combinations, achieves high blood pressure control rates and is very well tolerated. So thank you for listening to me, and let me hand it back to our moderators.
Nice to hear from the current trend in hypertension. I would like to start with a few questions you have. When you said the triple combo of the ARB plus amlodipine and the diuretic, now which any diuretic you prefer, like hydrochlorothiazide versus chlorthalidone? We used to believe more of a chlorthalidone. We say for the role in hypertension management. What is your opinion? How do you use 50
I have to apologize, but the audio perhaps on this side of the world isn't coming through very well, and I did have trouble hearing this at all.
Can you hear me now, Michael? Can you hear?
Yeah, let me try again.
Can you hear me? Which diuretic is your choice, hydrochlorothiazide or chlorthalidone?
Well, chlorthalidone is a very good diuretic. And if it were up to me, it would be the main diuretic that we would use for treating hypertension, 12.5 or 25. And I hope that in the future we will move away from hydrochlorothiazide, though it's done a very good job for us. But I would recommend chlorthalidone. It's more powerful. And when you give it in combination with an ARB, particularly a powerful one like olmesartan, the problems of the thiazide diuretics like hypokalemia and changes in glucose and so forth are basically do not occur. The angiotensin receptor block is able to prevent those abnormalities. So you can use chlorthalidone, and it's very well tolerated and particularly effective.
What about beta blocker in your practice? Beta blocker for hypertension. Like European guideline is the only guideline which mentions beta blocker for uncomplicated hypertension. And that is very relevant
Yes.
for India.
Yes, we've gone through changes with the beta blockers. For years, they were the recommended first-line treatment. And then when the ACE inhibitors, the angiotensin receptor blockers, and the calcium blockers came along, the beta blockers, at first we thought they were not as good as the other drugs in terms of preventing outcomes. And so they were not recommended as first-line treatment. And there is still a little hesitation with some people. However, they do work well for reducing blood pressure. And so many of our patients have a real need to have a beta blocker. I mean, if you have atrial fibrillation, you need a beta blocker for rate control. If you've had a history of a myocardial infarction or major coronary disease, you probably should be on a beta blocker. If you've got tachycardia, you should be on a beta blocker. Obviously, if you have heart failure, you should be on a beta blocker. So they are very important. And the European guidelines, the guidelines of the European Society of Hypertension actually say, you know what? We've changed our minds, and you can use a beta blocker as first-line treatment if your patient likes those drugs. So yes, they still have a part to play. I noticed that the European Society of Cardiology says use them when they're necessary, but they're still a little reluctant. And I don't know what the American guidelines are going to say when they come out. If I assume they're going to come out in the next couple of years. I'm not sure what they're going to say about beta blockers. But yes, beta blockers are back, and particularly the newer ones. There are some very nice newer types of beta blockers. It doesn't have to be propranolol, doesn't have to be atenolol. In fact, I think there are beta blockers that are far better than atenolol. And they should be used. Absolutely. I'm glad you brought that up. That's a very important point.
The main point, Michael, here, I was not saying about the compelling indication. The European guideline mentions even as a monotherapy or in combination beta blocker in hypertension. What is your take on that point? Can you hear me? Or is a compelling indication fine? when patient is a coronary artery disease, heart failure, atrial fibrillation, fast heart rate, but without those non-compelling indications. Role of beta blocker, because we have, in India, quite a big epidemiological study where we have shown that our resting heart rate is around 80, 82. And we have, this sympathetic overactivity. So heart rate control is an important thing along with the hypertension. And we have many other comorbidity with hypertension.
Yes, when beta blockers first came out, they were very exciting drugs because they were the first opportunity we had for blocking sympathetic activity with drugs that were well tolerated. And yes, I know in India there's a lot of interest in particularly using beta blockers for patients who have high pulse rates and who have evidence for sympathetic overactivity. And they work very well in combination with all the drugs we've been talking about. So I have no hesitation at all in using those agents.
Christopher, you got anything to ask from Hyderabad? Or Pennan? Can't hear you. Michael, what do you predict in your next American guideline? Because we were the follower of your last JNC 8 guideline, because those were very, very pertinent to us Indian patients. Now European guidelines are saying high normal, 3 classifications, isn't it? What do you predict in your next American guideline, hypertension management?
Well, I think the next American guidelines are going to be interesting because there's now an acknowledgement that here we have guidelines. We're telling people to get their blood pressure reduced to less than 130. Meanwhile, in the United States, not even half the patients being treated have the pressures reduced to less than 140. And if you ask the question, what percent of patients have their systolic pressures reduced to less than 130, it's only 26%. That's terrible. And so I know, and I don't want to violate any confidences because these guidelines are supposed to be confidential until they're released. There will be a lot of emphasis on what they call implementation. And the discussion we've already had about how to get patients to take the medications, how to get patients involved in their own care, how to bring other factors into play to get blood pressure better controlled. For instance, should we be advocating, for instance, diabetes has done quite well in the United States because we now have a new profession called diabetes nurse educators. And I suspect you have the same in India as well, where you have people trained in working with people with diabetes and helping them to get the best possible results. We need to do the same in hypertension, because if doctors are too busy to spend quality time with their patients, I mean, I find when I see a patient for hypertension, particularly if there's any difficulty, it takes me 15 or 20 minutes at least to have a good visit. I can't do it in 8 minutes or 10 minutes. But if I had someone in the room next to me who's trained just in hypertension and can really work with that patient and give them all sorts of hints and suggestions, that I think would be a huge benefit. That's the sort of thing that I think the American guidelines are going to be addressing. We don't need guidelines anymore. We've got excellent drugs available. We have well-tolerated, very effective drugs. We know quite a lot about lifestyle changes. I think internationally, we all agree what the targets of treatment should be. The problem is getting the job done, making sure that patients actually get the benefit of all this knowledge. And so far, we've failed. We're not doing a better job now in 2024 than we were doing back in, I don't know, 2010. I mean, in the last 10, 15 years, things have not improved, despite the availability of terrific drugs and terrific information.
Michael, anytime is a role in hypertension management or all the time are angiotensin receptor blocker for all the patients or anytime you feel ACE inhibitor is better. Our personal experience here is ARB for all in general. We also believe that because we have ACE inhibitor, a lot of side effects like cough and all in our part, it is quite a bit. And we don't want to give any drug which has side effects. What is your practice? ACE inhibitor, anytime you select hypertension management.
No, I really don't have anything to add to what you said earlier and now. I think we have to be thinking along those lines. You're absolutely correct.
What about systolic and diastolic? Because that's one of your, favorite topic. That like an elderly who have got a coronary artery disease. When we reduce the systolic pressure, diastolic also goes down. Are you really worried if the diastolic goes to 60 or say 65? What is your systolic is more important? Because I remember you saying systolic is more important in our earlier meeting.
Yes, that's a difficult problem, except I don't think it's as much of a problem as people think. If what we do is treat systolic pressure and are successful in reducing systolic pressure, then the patient will tolerate a low diastolic pressure. In the SPRINT trial, a lot of patients who did very well in the SPRINT trial and had very good outcomes finished up with diastolic pressures in the low 60s. In fact, many of them in the 50s. The reason we worry about low diastolic pressures is because, as we all know, the coronary circulation fills during diastole, and we worry if diastolic pressure is too low, we're not going to get adequate coronary filling. That's true. But if the systolic pressure is also low, then the myocardium has far less work to do to pump against that resistance. And so it can tolerate perhaps a small reduction in blood flow during diastole. So I think people who worry too much about low diastolic pressures, that's not as much of a problem as we think. I get the systolic down, I think everything will still be okay.
Friends at the other metros, you can hear me, all of you?
We have a question, sir, from Hyderabad.
Yeah.
Okay. Dr. Weber, again, thank you for that wonderful lecture. It's always good to hear you. So we have some two interesting questions from here. And one is telmisartan versus olmesartan. What is your pick? And we use a lot of telmisartan in our country.
Yes. Now, I'm very familiar with both drugs. And of course, both drugs are here available in the United States. Olmesartan is the dominating angiotensin receptor blocker in this country. I mean, people are using losartan and valsartan and irbesartan, all of them. But basically, olmesartan is recognized as the most powerful of the ARBs. Telmisartan is a very effective drug too. And it's been used in some important clinical trials and shown to be effective in helping to prevent cardiovascular outcomes. So even though I use olmesartan mainly and Actually, for my own hypertension, I would have no problem if someone said they wanted to use telmisartan. I just think those extra 4 or 5 millimeters of mercury with olmesartan, and it's so well tolerated. To me, that's a bonus, and I like that. I think it's just a little bit of an advantage.
Second question, Dr. Shetty. Can we have one more question?
Christopher, just 1 minute. What
Okay, sure.
property of olmesartan, something over telmisartan, anti-inflammatory better properties and all? What property of olmesartan you think better than the telmisartan? Yeah, Christopher, you can go ahead, I think. Christopher, you can go ahead.
Okay, sir, we have another question. In CKD patients, how low can we go in terms of GFR when we're using olmesartan? What is your safety net in your practice?
Well, I think we all accept that the angiotensin receptor blockers are the treatments of choice for people who have chronic kidney disease, estimated GFRs below 60. We use them, the ARBs, to get the blood pressure down to acceptable levels. Sometimes people worry when you use an ARB and you reduce the blood pressure, you get it down to, let's say, somewhere in the 130 range, around 130 or even the high 120s. They worry because sometimes the creatinine increases, particularly when you've had a big fall in blood pressure. And that I can understand people worrying. It is normal for the creatinine to increase by about 30%, up to 30%, when you start an effective angiotensin receptor blocker. And over time, months, maybe up to a year, the creatinine and the estimated GFR will come back down to where they were before. The GFR will go up and the serum creatinine will come down. So I am not afraid to use the ARBs. When you think about it, it's the blockers of the renin-angiotensin system, particularly in diabetic nephropathy, and particularly the angiotensin receptor blockers, that are the drugs that have been shown best to protect the kidneys and to protect patients from progressing to end-stage kidney disease.
Sir, you want to ask from Bangalore? Sir, you can hear me? From Kannan, from Chennai?
No, it's so funny.
We some questions from Kolkata. It's always glad to listen to you. We learn a lot. So I need to know what is a personal view of just getting sacubitril valsartan for the management of hypertension, primary essential hypertension in future in the guidelines.
And now you asking about
our needs in getting control of primary essential hypertensions in letting the guidelines.
Yes. Well, in India and Europe, I think ARNIs will be very popular because they're well tolerated and they are a bit more effective than the angiotensin receptor blocker alone because you have the benefit of the sacubitril, the enhancer of the natriuretic peptides, which adds to the antihypertensive efficacy. And in the United States, we have the ARNI, and it's obviously used for heart failure. That's an absolute. We have to use it for patients with heart failure. Strangely, it is not promoted in the United States or available for the treatment of hypertension. We do not have it here, unless and since it's a relatively expensive drug, I cannot get it available for my patients unless I say they have heart failure. So I don't have the flexibility that you have in India. But I was a big believer. In fact, I worked with the company that developed the combination of sacubitril with valsartan. And when we started doing the research, it was for hypertension, and heart failure was a secondary consideration. As it turned out, it was pretty good for hypertension and very good for heart failure. And it was launched in much of the world for hypertension and for heart failure, but not in the States. I think it's a very good treatment for heart failure. I wish I had it here in the States. And I think we're going to see more and more of it being used for difficult to control hypertension, because the natriuretic peptides is a totally different mechanism of action to anything we've got up till now. So yes, you'd love to have that available.
My second question is, which we will prefer between olmesartan and telmisartan, especially in patients with insulin resistance type 2 DM with associated hypertension, and for why, what are the reasons?
I've come to the conclusion that the angiotensin receptor blockers are basically equally as good. It's just now a matter of which one is most effective at reducing blood pressure. Different ARBs have been used in different clinical trials, whether it's kidney disease or heart failure or other kinds of outcome studies. But frankly, they all work well, and the ones that are most powerful are the ones I would choose. I think telmisartan became popular in India because it was more powerful than valsartan and losartan. And then more recently, along comes olmesartan, and it again is a bit more powerful. I have no problem with telmisartan, but I do think olmesartan does offer that extra 3 or 4 millimeters of mercury, which I think is very helpful.
My third question is, if you are using a combination of antihypertensive agents, which is including a diuretics, so whether you prefer to give it in the morning or at the night?
If I am using a diuretic, I tend to use it in the morning, just in case, because I worry if I use it at night, the patient may have to get up at night to avoid their bladder. I don't think I should worry as much as I do, because once a patient is established on a long-acting diuretic, they're not making more urine than they were before. They're just holding things at a slightly different level. So I do have patients who take it at night because it's more convenient for them, and I don't hear any particular complaints about it. But if I'm not using a diuretic, I personally prefer taking it at night. And the reason is if people do get a little bit of hypotension, sometimes they're not going to notice because they're sleeping. And one of the questions I get asked a lot, particularly by younger and middle-aged patients, sometimes by older patients, is I like to get up in the morning, they'll tell me, and I want to go out for a nice long walk. I love exercise. Should I take my medicine before I go walking or after I go walking? And the answer is I don't know. So I figure if they take it at night, they won't have to worry about it. I find it's very well tolerated and very effective if taken at night. So it's truly, as the guidelines say, it's a patient's choice.
So in patients with hypertension with CKD, so do you think if they are not being controlled with any of the drugs, it's isosorbide dinitrate with a hydrolyzine combination, they may be effective in controlling that in refractory hypertension in CKD populations?
Yes, CKD population is hard to treat. It's very difficult to treat. And Now it's become more complicated because we're using drugs that in the past we didn't necessarily realize were good for chronic kidney disease. For example, the mineralocorticoid receptor antagonists, spironolactone, eplerenone, and now some of the newer ones like finerenone, which are very well tolerated and very beneficial for people with chronic kidney disease. And they also help to lower the blood pressure. Similarly, more and more we're using the SGLT2 inhibitors in our patients with CKD. They're very effective again at protecting kidney function, and they also have a modest but very useful blood pressure effect. So we have some terrific choices now for people with chronic kidney disease.
Dr. Kannan from Chennai.
We asked some questions from Delhi.
Yeah, Rajiv Agarwal, you can.
Okay. I'll just ask you two questions. See, regarding Dr. Weber, so in your practice, what is your prevalence of true resistant hypertension? True resistant hypertension in your clinical practice. True resistant hypertension. How many percentages?
Rajiv Agarwal, you can hear me?
Hello? Am I heard?
We raise the volume.
And then we can't hear you.
Yeah, see, the prevalence of true resistant hypertension in a practice and the role of renal denervation.
Okay, now I hear you. Renal denervation has been approved in the United States. I understand it's also available in India. Look, it's an intervention. It's going to take 3 or 4 hours for the patient to come into a facility. It means going into the renal artery. It involves cutting down into the arterial circulation. It's effective. It's about as effective as a drug, as a typical antihypertensive drug, 8-10 millimeters of mercury systolic, perhaps. So it is useful. And where does it fit in? Well, first of all, the patient has got to want to do it. And normally I don't worry about a patient taking pills. Everyone in the modern world takes pills for one reason or another. But do they want to go through what's almost like a surgical procedure? And our studies have shown that about 40 to 45% of people are willing to do that if we can promise them that they got a good chance of getting a nice blood pressure effect. And that I think is reasonable. And we have found that when we've been doing the clinical trials with renal denervation, there are plenty of patients who want to try it and see if they get a benefit, and quite a few do. And I've been impressed by the registries of patients now with several thousand patients who've had renal denervation, particularly in Europe, how once they've had the renal denervation, their blood pressure did come down. And it stays down now. They've been following them for 3 or 4 years, and the pressure remains very well controlled. So I think it will have a role. I think it will be very helpful for some patients. But I think before we rush off and do a procedure like that, we want to make sure we've done everything we possibly can using medications responsibly. I keep on saying that about 80% of patients can be controlled pretty easily with medications. But 20% is still a lot of people when you have hundreds of millions of people, as in India, who've got hypertension. And so I think it will have a part to play. It's expensive, it's procedure, but I think it will have a part to play. And in India, you're much better than we are in the States in making these sorts of procedures affordable. So it may do better in India and be used more frequently in India than even over here in the States.
You see that the contraindication is less than 40. The renal denervation is contraindicated in less than 45 GFR. But what is your threshold for starting? For example, you have a GFR of about 60. Would you do it confidently in that group, which a patient who needs it? Are you comfortable with the GFR, which is what is the lower limit of GFR? You're comfortable in doing renal denervation.
Yes, that to me is not a big problem. The reason it's not approved for eGFR of less than 45 is because the clinical trials, not knowing what might happen to renal function, did not include any patients who had eGFRs of less than 45. So we don't know what happens in people with eGFRs of less than 45. What we have learned, though, is that renal function, if anything, is slightly improved following renal denervation. And that's kind of encouraging. So if I had someone whose eGFR was in just above 45, I would not worry. I would not be thinking, oh, I hope I don't make things worse. I think if anything, things will get better. So that's fine. I got a feeling somewhere along the way, one of the companies that makes renal denervation catheters is going to do a study in patients with chronic kidney disease, even in the range 30 to 45. And I wouldn't be surprised if that turned out to be very successful and very safe.
Thank you, Dr. Weber, Dr. Sadan. Thank you, Macleod. Thank you.
We have 3 questions from Bangalore. The first question is, any alternative to calcium channel blocker amlodipine approved by US FDA? Is the first question from Bangalore. I repeat, any alternative to calcium channel blocker amlodipine approved by US FDA?
Yes. Yes, amlodipine is approved by US FDA. In fact, it's our most commonly used calcium channel blocker.
The question is, we have many CCBs are available in India. Is beyond amlodipine is the US FDA approved, like cilnidipine or azithromycin and all? Are they approved US FDA? Or CCB only use amlodipine?
I think we lost Bangalore.
Okay, you can go on to the next question.
My next question is, in practical world, olmesartan is better than telmisartan or not? And is olmesartan 20 mg dose is effective? Is my next question.
Yeah, olmesartan, I don't like using the word better, but yes, olmesartan, as far as I know, is the most efficacious of all the angiotensin receptor blockers. And to my mind, that means if I'm using it, I'm going to get another 3 or 4, maybe 5 millimeters of mercury, perhaps more than that, compared with something like losartan. Telmisartan is quite strong, but it's still a difference of about 4 millimeters of mercury. To me, that's an important difference. And if olmesartan is available to me, I would prefer to use it. Now, I've used telmisartan. I think it's a great drug too. But olmesartan does offer that little extra efficacy.
My next question is, malodor of olmesartan is a issue or not? What is your opinion on combination of bisoprolol plus dapagliflozin in hypertension management?
Well, bisoprolol plus, did you say dapagliflozin?
Beta blocker and SGLT2 inhibitor combination, is it efficacious in the management of hypertension?
Yes, that's a good question, because in general, beta blockers have not been that additive in terms of blood pressure reduction with blockers of the renin-angiotensin system. But once you get to drugs like bisoprolol, which are quite different as a beta blocker, I suspect it would work very well in combination with an angiotensin receptor blocker. In fact, I believe there is even a product in India, a fixed combination of those two kinds of agents, and apparently it's very effective. So yes, I think that is perfectly acceptable.
See, hypertension is a very common disease in India, and the control of blood pressure is very less in Indians. Most of the patients are not controlled, but they think they are controlled and they are having just medicines. So, what is your take-home message to have optimum blood pressure control?
The best way to improve blood pressure, the best way to improve blood pressure control is to get the patients involved. I find if I can just persuade them to measure their own pressures and write them down, if I can get, and sometimes it's important to see hypertensive patients with their families. So a man may be hypertensive, he should be taking his medications, he's not very reliable, but if his wife comes to the visit and she knows how important it is, she will make sure he takes his medications. So I think getting families involved and pushing some of the responsibility onto the patients themselves is definitely helpful. Right now, we don't have much else. Just to have more and more visits to a doctor doesn't help if the patient isn't taking medications or isn't taking the hypertension seriously. We really have to work on getting the patient to take the responsibility themselves. And that does help, but it's a problem we still are working on. It's not an easy problem to solve.
What is the role of lifestyle changes in controlling blood pressure? Lifestyle changes. What are the lifestyle changes we should advise to our patients to control blood pressure?
Well, you know, it's a big difference between theory and practice. And we all know if you lose weight, the pressure comes down. We all know if you eat less salt, the pressure comes down. We all know if you exercise, the pressure comes down. Well, that's terrific. And the patients know that. Everybody knows it, but almost nobody does it. In my presentation, I showed 3 or 4 slides on lifestyle changes because they are important. It's so difficult, though, to get people to do it. Some people, if they want to do it, will do it, and they'll do it very well. Particularly, people love exercise. That's the most successful because people sort of enjoy it in a way. And they like going out for a walk, sometimes with a friend. It's a nice thing to do, and that's helpful. But my gosh, it's so hard to change eating habits and the foods that we buy. And one of the sad things is healthy foods that are not high in calories are often expensive, right? Fresh fruit and vegetables, for instance, sometimes will cost more than high-fat foods, which are going to cause problems with lipids and cause problems with weight. But healthy food is sometimes not as affordable, and that's a real problem. people will eat what they can eat. And I think hypertension has to be seen as a public health problem. None of us as an individual doctor is going to solve the problem. It has to be done through organizations. It has to be done with the government and with other agencies that are going to help put safer, healthier foods out for people to eat, and to have public policies to do everything they can to help people get their blood pressure under better control. And for instance, in the States, some cities that take hypertension very seriously, you can go into any police station or fire station and they'll measure your blood pressure. Well, that's good, because it's not that so many people actually do that, but knowing that policemen and firemen take it very seriously makes people realize, well, if they take it seriously, then maybe I should be taking it seriously too. Whatever you have to do, but it has to be done thinking in terms of public health, not what I can do individually with my patients in my own practice. That's important, of course, but we need help from the community as well.
Dr. Arvind, we'll allow Dr. Rajiv Agarwal to ask him. Rajiv Agarwal from Delhi. Yeah.
Hello, sir. This is from New Delhi, and we all enjoyed your presentation and your insights very much. I just wanted to ask, when we choose our ARB for hypertension, do we worry at all about the earlier studies which talked about an increased cardiovascular mortality with olmesartan? Has that doubt been completely laid to rest? Or are we still a little hesitant about olmesartan for cardiovascular mortality?
Oh, yes, that's very definitely been laid to rest. It was a very poorly designed, poorly executed study. There is no evidence to support that. And in fact, the FDA went through all of the data very, very carefully. And the label for olmesartan is the same as for every other ARB, which says, and it's very interesting, this is the FDA's label, it says high blood pressure is associated with an increased risk of strokes and heart attacks. Olmesartan reduces blood pressure, which is known to reduce the risk of strokes and heart attacks. So olmesartan actually can claim the opposite of what you're worried about. I know that study. I know the people who did it. It was a disaster. It was just poorly designed, poorly conducted. Just went. It was a great lesson in the importance of doing things properly.
So we should not bother about the roadmap study at all. That is very good to know. When we start an ARB in patients who have an impaired GFR, is there any eGFR threshold below which you would not choose to start an ARB in patients?
Not really, no, because the ARBs are the only drugs that we've had that have been shown as antihypertensive agents have been shown to slow down the progression of kidney disease, even in patients who are getting into that range of end-stage disease. Now, there are other drugs that should be used as well, along with the angiotensin receptor blocker. And we can talk about SGLT2 agents. We can talk about drugs like finerenone, the mineralocorticoid receptor antagonist. Even GLP-1 agents recently were shown to be beneficial in these sorts of patients. So there's a lot of things we can do for these people with end-stage kidney disease, but still the foundation drug for renal protection still is the blockers of the renin-angiotensin system, the ARBs, and the ACE inhibitors. They are very effective, and yes, they may at first appear to raise the creatinine, but that is purely a pharmacologic effect. It is not a sign of them worsening kidney function. And in fact, over time, they protect kidney function and reduce the probability of patients progressing to end-stage kidney disease.
Respected sir, my question is very straight. If the blood sugar, or if the serum creatinine is 5 and blood urea is, let us suppose 100, is it possible to continue the olmesartan one? Secondly, it has an effect on calcium and sodium problems.
Yes, yeah. As far as I'm aware, there is no none of those issues would persuade me not to continue using the angiotensin receptor blocker. It really has very modest effects on glucose, but they're beneficial, if anything. Very modest effects on other things we measure metabolically. No, I would not be concerned about those issues.
But potassium also, it has no effect on potassium too.
I'm sorry, didn't quite catch that.
It has no effect on serum potassium of the patient in CKD.
I didn't get your question.
It's okay.
No, what did you say?
Effect of olmesartan on serum potassium in CKD patients.
Yes.
That's
Serum
my-
potassium? Well, the potassium does increase to some extent with the use of ARBs, and we have to figure out how to handle that, particularly in those people who also need to have a mineralocorticoid receptor antagonist. And we can deal with it either by intensifying the diuretic. We may have to use a loop diuretic like furosemide. We may have to alter a patient's diet. And we now have ways of treating hyperkalemia by the use of orally taken medications that bind to potassium in the bowel and help to reduce serum potassium that way. But
I understood from this that there is a indication that if hyperkalemia is there, we have to go for dialysis. So I would understand if I am to continue olmesartan, I have to manage the hyperkalemia side by side if my patient is CKD patient. Because I understood from your point of view, and I am thankful to you for this guidelines. Thank you.
thank you.
Some time here to close the session and everything must come to an end. We would like to thank you for your brilliant talk, and I would like to express my thanks to all. And with this, I would like to hand over the thank you, Michael. We are going to meet again next Saturday. Yes, because like your host, each and every one of you, and we take this opportunity to esteem the speakers, Michael Bema, but we also thank the moderator, so the huge thanks to Rajiv Vikwan, Delhi, countries in Delhi, and this library. For wonderful some the systems of hypertension, ensuring that
translate to health. So we are very sure that the system that will attended would help audience ultimately empower them. And some of these design are the audience to practically know, but they are not paid. Now, and we engage designs or which you very Maybe this